In the first part, I introduced the concepts relating to health and society that we'll discuss. I'd started to talk about the rise of the biomedical culture and the power of medical professionals. Understand that the impetus for professionalism is perhaps a century or a century and a half old, that up until that time physicians were held in generally low regard, partly because they did not have necessarily the kinds of tools that would make it possible to help their patients. Remember, of course, that there was a time when the work associated with surgeons was something that barbers would do, which is why you see the striped pole rotating in front of some of the barbers, because the red was a symbol of their profession. The fact that you see physicians being held in higher regard is not a universal either. That, for example, in the old Soviet Union, women were more often than not physicians because the position held such status or a lack of status in that particular society. In general, because of the limitations that existed for physicians to be able to deliver improvement, they were deemed incompetent. When you started to see improvements, they occurred in the 19th century. The reputation of physicians grew through the process of licensing, which was an objective mechanism to be able to winnow out those who in fact could not help these individuals. Licensing also ended up narrowing the supply of individuals, which helped to drive up interest in a particular field and competition, which in turn would have improved the quality of people who end up getting licensed to work as physicians. It improved the kinds of wages that these individuals had, since there was a finite number of them, and it increased opportunities for employment so that there were conditions that allowed for constant employment. Some argue that the status of physicians started to decline around 1990. Among the reasons cited for this kind of decline would be about the rise of market forces that were starting to raise the larger question of whether or not physicians were worth the cost. You started to see the influence of HMOs, health maintenance organizations, which through their ability to contain prices drove down costs, at least from their perspective. There was also a rise in external regulation. For example, the enactment of a federal law creating a Bill of Rights for patients, so that the physicians did not have the complete word on how to proceed with the delivery of health services. We started to see challenges from non-traditional medicine, which contributed to undermining the authority that physicians faced. You saw the rise of technology, where people ended up having the means to be able to, through technology, if not improve their condition, at least to maintain it. And then the internet itself, which ends up providing a source of information and thereby helps people to figure out whether or not they need medical treatments or services, or what would be appropriate on their part. I imagine, however, that many physicians don't care for the site WebMD simply because people end up going there, finding their symptoms, and thereby delivering a diagnosis, when the fact is that access to information does not necessarily result in sophistication of diagnosis. Approach this issue of health and wellness from a different perspective. What does it mean to be sick? A sociologist we've often talked about, Talcott Parsons, looks at the idea of what it means to be sick, characterizing it as the sick role, or the things that happen when one is sick. Among other things, this is worthy of a designation of a role because it means that individuals, no matter what their normal social roles, can shuck those roles while they're being sick. A sick person may end up not being held to the same levels of accountability as someone in a normal social role because of the health condition, that the sick role requires the person who is sick to assume the burden or responsibility for getting well, and that such a person should be cooperative and willing to follow the instructions of a physician. What this suggests, that is, Parsons' conception of illness as a sick role, is that illness is a social construct, that it is going to be dependent upon a number of forces which may vary depending on time and place. The upshot is, however, of course, with the sick role, is that the onus is on the person who is sick to initiate the process of diagnosis and treatment, and then if there is some way in which the patient can manage treatment of the illness, has an obligation to do so. Think about what it means, however, to socially construct illness. What it means, amongst other things, is that time and place are going to affect what it means to adopt the sick role. Think about alcoholism, for example, where it has been effectively medicalized today, characterized as a disease. Not so long ago, some would regard alcoholism as a moral failing, or even evidence of a spiritual disorder. What that effectively meant is that the regard for the individual was different than, say, someone who had contracted a communicable disease. Think also of the way in which the social construction of illness has changed when talking about autism. Instead of considering autism to be a single concept, and therefore people who manifested some of the symptoms would not truly be autistic, autism is now characterized as a continuum, so that there are varying degrees to which autism exists in individuals. What that meant is, amongst other things, you see an increase in the rate of autism in this particular country. It's not so much that autism itself is increasing, as it is the means of identifying it have changed and therefore expanded the classes of individuals who experience autism. Look also to the way in which characterization creates stigma in the form of labeling, that it means that being autistic is different than normally developing. But that too may end up changing out of recognition of the fact of the stigmatizing effect. And that by recharacterizing autism as a continuum means that individuals have a sense of place or community, and also that there may be strategies that address the particular combination of attributes that would lead to a diagnosis of autism. Consider the U.S. healthcare system. In fact, look at it with in light of recent social changes. Traditionally, what we've seen is that medical providers would deliver services and receive payment, or fee-for-service type arrangements. Under an older model, this gave the physician much greater discretion when it came down to collecting a fee-for-service, that there could be adjustments made, but these would also be dependent on the standards of the physician or the physician's practice, rather than some sort of national standards. One effort to drive down, or at least to manage physician costs, would come through the creation of the so-called HMO, or Health Maintenance Organization. One of the ways in which the HMO would end up managing costs is to work out an arrangement with the physician or physician's practice, thereby guaranteeing the physician a certain amount of payment for patients, and that this would create an incentive on the part of the physician not to treat people, which could of course mean undertreatment, and that certain illnesses would not get addressed. But it was also a way to help to put boundaries around the idea of expenses associated with the treatment. Another factor that has come to play is federal programs enacted in the 1960s. Medicare being health care provided for poor people, although this was a service that was an arrangement worked with the federal government and states. Consider Medicaid being different from Medicare. If Medicare dealt with people over 65, Medicaid would end up dealing with health care for those who who cannot afford health care. Both systems, however, are universal in the sense that with Medicare, all you needed to do was to turn 65, and with Medicaid, that those individuals who fell beneath a certain level of income would receive this kind of care. But it was really limited, and dependent upon the designation of what it means to be poor. One of the ways in which Medicaid has been constrained is that there has been little change in the definition of what is poor. Or you might have states' children's health insurance plans, SHIPs, as a way for providing for health insurance for children. Other states have taken a different perspective, and instead of creating a plan, merely made it free that anyone under 18 would receive medical care. Part of that thinking, besides the notion of humane treatment, that someone should suffer simply because of age and income, was that treatment at a younger age would potentially lead to fewer symptoms and illnesses later in life. What are the things that our society looks at to be able to determine certain kinds of health outcomes? We'll see an assessment of nutrition, of access to clean water, of making appropriate lifestyle choices, for example, not to smoke, managing the consumption of alcohol. We might look towards morbidity rates, which relate to the measure of illness, and mortality rates, which measure death. We might assess individuals through some class of measurements for humans, which would be, broadly speaking, anthropometric, because they are all relating to measurements. Look at the curious consequences, for example, of looking at height, that taller men tend to have higher incomes and are more politically powerful. We could also end up seeing that height could be a predictor of a larger degree of a dysfunction in society, perhaps not having the access to health care that would allow people to grow. We may see other factors that relate to determinants. You see higher sex selection rates occurring in China and India, where tradition has had the boy being the one who would be capable of taking care of parents in their dotage, rather than having any sort of state-based system that would care for the elderly. Also that in some societies, although even if illegal, the idea of a daughter would be deemed more expensive because she would often need to be able to bring something to the marriage in the form of a dowry, and so that would be seen as a drag on society. We might look at, once we have a child, to inequalities that arise. Low birth weight children have, generally speaking, lower educational rates of attainment and lower socioeconomic status, although this has been on the rise in our society. What is it that accounts for the fact that African American infants are more likely to die from an illness than their white counterparts? Perhaps the stressors of day-to-day life account for this. The anecdote that's related in the book to support this is the story of the worker John Henry, who's renowned for being able to lay down rail tracks for railroads, was so great that in a contest between him and a mechanical device, he barely beats the machine in terms of proficiency, but that he dies from exhaustion because of this. Look at socioeconomic status. Generally speaking, should there be a link between socioeconomic status and health? One of the ways in which you might expect that lower income produces higher morbidity, selection theory suggests that that is a spurious or invalid relationship. Drift explanation asserts that health causes social position, so that those who remain healthy are able to achieve greater levels of success, and that a variation on this theme looks to social position being produced by health. That if one is well off, for example, there may be less stress in one's life, there may be access to the material goods that make life easier, that the influence of changes to social policy may not be as dramatic. One's marital status, generally speaking, seems to be beneficial. It's not perhaps so much the institution of marriage itself that produces this effect, but perhaps the change of behaviors that come through marriage, reducing risky behaviors or unhealthy eating habits. You might see that there are differences due to gender. Generally speaking, women live longer than men. Perhaps that's due to the notion that under the traditional model of men being breadwinners, the sole source of support for a family, they experienced greater stress. It could also be to the fact that women end up being more likely to seek health care than men would. What about family structure? It may turn out that larger families do have higher child mortality rates, and that firstborn children are more likely to die young. What accounts for this? Maybe the notion that the family only has a certain amount of resources to be able to take care of these additional children. With the firstborn child, the couple is so comparatively young that they haven't amassed the resources to be able to receive proper care for the child. Consider the topic of mental health. The whole notion of mental health seems to have adopted the so-called medical model. When you look back to the very early stages of psychiatry, you see physicians being the ones who are trying to grasp or conceptualize the notion of mental health. Look at the fact that someone like a Freud came from a physician's background. What extends this is the notion that mental health lends itself to diagnosis, to a standardized document of measurement, colloquially known as the DSM, or the Diagnostic and Statistical Manual. One of the benefits of this is that it would create standardization, but perhaps one of the complicating factors is that mental illness would then be a social construct, would be something that has to be characterized there. Even so, you didn't see that the DSM had the impact that it did until roughly 1980, with the third edition coming out, where there was a much greater emphasis on the medical model. Why that change? Perhaps because of the way in which insurance had come to rely on the diagnosis as a way of figuring out how to make payments, and that therefore you would see changes in diagnoses, the descriptions of diagnoses, to increase the level of accuracy and to provide criteria for the health insurance industry to be able to figure out whether or not to make a payment to a physician for the delivery of services. You may also see the rise of the medical model for addressing mental health, because some forms of mental illness could be, at least their symptoms could be addressed through the introduction of a medicine. And so you see with psychiatry a greater emphasis on the prescription power of physicians, the ways in which they can help to alleviate the discomfort that comes with mental illness. But there's a fundamental divide here. At least at this time, broadly speaking, psychiatrists are physicians with some background or training in mental health. As physicians, they're capable of being able to prescribe medicines. Contrast them with psychologists, who generally don't have prescription writing authority, but more significantly, regard treatment as something that would occur through a personal relationship rather than through the delivery of a medication. So that psychologists would be more typically associated with talk therapy as the means of being able to improve someone's state. Yet insurance might be more skeptical of its effectiveness than, say, with the medical model advanced by psychiatrists. Consider the issue of health on a global scale. Even though the United States might have relatively high socioeconomic status amongst its citizens, it does not have the highest life expectancy in the world. Rather, it ranks, at least according to the text at the time of publication, as the 29th highest life expectancy. So how is it that so advanced a society can't do better? Maybe the argument has to do with the unequal distribution of healthcare services. And what may be curious is that now federal law compels people to have medical insurance, whether or not the availability of health insurance is going to improve the quality of life in our society. Note that the primary cause of mortality in societies is waterborne illness, so that simply having some sort of clean water supply can reduce mortality, something that we have in our society, generally speaking. Waterborne illnesses could also be disease vectors, that you might see malaria arising because of mosquitoes passing along the illness, and that they'd be associated with certain freshwater sources. Malaria being so widespread a disease that it has accounted for the loss of many millions of lives, but also being the kind of disease which may, with time, be protected through vaccination and become, if not a manageable disease, become effectively extinct. So a disease that had been the source of great illness and occasional death, polio, could be reduced to a relatively rarely seen form of illness, or even like smallpox, which would end up through vaccination becoming almost medically extinct. If you're considering global health, look at the impact of a disease like AIDS being produced by HIV, that it has killed perhaps 500,000 Americans, but worldwide something on the order of 25 million people, that the way to manage the transmission of the virus seems through changing the patient-physician relationship so that there's a greater emphasis on prevention rather than costly treatment, although even the costs associated with the treatment of HIV have decreased over time. We've seen other measures used to be able to manage the transmission of the disease through the breaking of patents for medicines, that some nations find that the patent holders asked for too much money for the medicine. What has actually ended up happening is that the pharmaceutical companies work out some sort of arrangement with nations so that they retain patent protection but are able to deliver a certain amount of the medicine at a certain cost. Can health care costs be reduced by preventing bad behaviors? Consider the fact that we already have in our society so-called sin taxes, that the consumption of alcohol or that smoking was considered a sin. We're talking now not a medical model but a religious model for health care, and as a result the consumption of those items was deemed more acceptable to be taxed than not. But extend the concept a little further now, something like a junk food tax or a fat tax, so that there would be some sort of use of taxation to shape people's behavior through the to discourage the consumption of those food items which end up making people's health worse. Whether or not that's something that will come to pass is to be seen. Efforts at trying to be able to manage obesity, such as limiting the amount of soda, have generally failed because, in part, they seem to be a kind of a crude approach to addressing a serious problem. All that being said, let me end here the lecture for Chapter 11.